Good afternoon and welcome to today's Payment Transformation webinar. I'm Paula Murray with HMSA's Provider Services Department. As you saw on the earlier slides, if you have any questions, please be sure to type them in the chat box. We will get to the questions at the end of the webinar. If we don't have time or if we're unable to answer your question, we will respond to you individually by the end of the day today. So now that we're well underway with all of our POs fully integrated with payment transformation, based on feedback from all of you, we've implemented some changes to the payment transformation program for 2018. And today I'll be sharing with you the changes that affect measures that have been carried over from Pay for Quality, as well as measures that are new for those of you who were on Pay for Quality through the end of last year. We'll briefly cover the engagement measures and the tools available to help you succeed in the payment transformation program. At the very end of your handout, you'll see some slides on patient attribution. We won't be covering these slides today, but I just wanted to include them for your reference because we did make some significant changes to attribution last year. You may have already heard that we will be transitioning from COZIVA to Choreo in April of this year. However, for the first quarter, January, February, and March, please continue to use COZIVA as you have in the past. You will continue to be scored on your office's use of COZIVA, and I'll cover that more in detail when we get to the engagement measures. If you've been on the Pay for Quality program through the end of 2017, you'll notice a few changes when you check your COZIVA display. One of the first things you might notice when you log into COZIVA is the menu on the left side of your screen. The icons are pretty self-explanatory, but I'll go over some of the features that you see today. So for those of you who were still in Pay for Quality through the end of the year, last year, this is what you will be seeing in your new COZIVA display. And using the left side menu, if you select Registries, it'll bring you to this screen, which is the payment transformation view of COZIVA. It displays each measure, your current performance in each measure, the minimum and target thresholds, as well as your denominator for each measure. You'll be able to see your entire denominator for each measure. So very different from Pay for Quality where you had rolling quarters and your denominator changed each quarter. In the new view for payment transformation, you'll see all of your patients in that denominator, and if they're due for that measure this year, you will see a red dot next to their name. So this is really nice because it allows you to see at a glance which patients need attention for the measure through the end of the year. The PCP's performance rate for each measure will be measured against a minimum threshold and a target threshold. The achievement of the minimum threshold will earn the provider 40% of the maximum payment potential for the measure. Achievement of the target threshold will earn the provider 100% of the maximum payment potential for the measure. A performance rate between the minimum and the target threshold will be paid incrementally, and the PCP may also earn up to 50% of the maximum payment potential per measure for improvement in their performance rate from their baseline period performance rate. And the baseline is taken from your scoring of the previous year. So in total, PCPs can earn up to 110% of their maximum payment potential per measure for performance above the target threshold. You could refer to page 22 of the Payment Transformation Guide for a detailed list of all measures along with the minimum and target thresholds for each measure. Clicking on your performance bar for an individual measure will open up a box, and that will drill down with details for each line of business pertaining to that measure. So here you can see how you're performing across each line of business for that particular measure. You may be excelling for one line of business, but may have some work to do in another line of business. So as you see on your screen here for this example in Medicare, this provider is doing really well at 91%, so they have a green bar. They've surpassed the target threshold. In the commercial line of business, they've met the minimum threshold, so the bar is yellow, but they have not yet reached the target. And for Medicaid or Quest line of business, that bar is red because they haven't yet met the minimum threshold. The next feature I wanted to talk about on the dashboard, it's the dashboard that you select from that left side menu. The components on the dashboard will show you the current patient count by line of business, and that's indicated by the dark blue bars at the top of your screen. Right below that is kind of a medium blue bar, and that will show you the dollars earned bar. Then just below that, you see sort of a bar graph. So that's your PCP for Performance Measure Summary Graph. And this compares you or your PCP with other PCPs in their PO, as well as compared to the network average, and that's shown in yellow. So on your screen, the very first one is the network average. The second yellow bar is the PO average, and then the other PCPs in your PO will be shown in gray, and you're shown in blue. So you can see how you're performing against your PO, individual doctors in your PO, and against the network in general. On the right-hand side of the screen, you have a lot of other nice features. You have your top 10 list. The top 10 list is right below the bar graph. And that tells you your top 10 patients who have the most gaps in care. Then moving over to the right-hand side, you have your total cost of care breakdown bar, and this shows you where your costs are distributed, whether it's office or hospital visits, imaging, emergency department, or other areas. Then the total cost of care per member per month will show your current cost PMPM. Clinical panel risk score. This is the current risk calculated for your patients based on the data that we received for a 12-month period. And for the current period, we're looking at August 2016 through July 1st, 2017. So it takes some time once you've submitted your claims with diagnosis data. We'll compile that data and calculate the current risk score. And the last feature on this screen is your hospitalization activity chart. And this shows you patients who have been discharged from the hospital in the last week. As I mentioned previously, on the far left side of the Coziva dashboard, there's a menu for the various functions. By selecting the lotus flower in the top left corner, this toggles the left navigation menu. So once you click on that lotus picture, you'll get this other menu that pops up. You click on that arrow and you see the options for registries. From there, you can view your payment and engagement HTML report. So those are the top two options. So this is an example of an HTML report, and it's the same report you found in Coziva in the past, just the location of how you get to it. The link to the report is now in the side menu instead of the bottom of the page as it was in the past. Okay, now let's move on and talk about performance measures. Performance measures will be scored annually on an individual PCP basis by line of business. All participating PCPs, regardless of their specialty type, are scored on all measures for which their member panels are eligible. The performance measures were selected for clinical importance and focus on meeting new goals for patient care, including prevention, well-being, access, patient-centeredness, and population health management. In the Payment Transformation Program, the performance measures are all scored on a calendar year basis, not on rolling quarters as they were in Pay for Quality. This is nice because, again, if your patient comes in to see you early in the year, you can see all gaps that apply to them for the entire year. The majority of the performance measures in Payment Transformation are measures you're very familiar with and have been carried over from our Pay for Quality program. We'll continue with preventive cancer screenings for breast, cervical, and colorectal cancer. The 4 diabetes measures will also continue to be measured in Payment Transformation, and these are the diabetic eye exams, medical attention for nephropathy, HbA1c levels at less than or equal to 9%, and blood pressure control at less than 140/90. Advanced care planning and BMI have also been carried over as performance measures in payment transformation. Well child visits in the first 15 months of life and well child visits in the 3rd, 4th, 5th, and 6th years of life will continue to be measured, as well as childhood and adolescent immunizations. Weight assessment and counseling for nutrition and physical activity for children and adolescents are also being included in the payment transformation performance. And of course, our review of chronic and suspect conditions for the Akamai plan have also been carried over. If you moved from pay for quality to performance measures this year, you'll see there are only 6 measures that are new compared to what you're used to seeing in the pay for quality environment. And these are tobacco screening and cessation counseling, screening for symptoms of depression and anxiety, flu vaccine, adolescent well care, developmental screening in the first 3 years, and the Share Care Real Age Assessment. The first new measure, tobacco screening and cessation counseling, looks at the percentage of attributed members 18 years of age and older who had an outpatient visit with an eligible PCP type during the measurement year, and that they were screened for tobacco use and had tobacco cessation if screened positive for tobacco use. I also want to point out at the top of the screen, the top right corner, you can see on this screen it has CQM. So these stand for Commercial, Quest, and Medicare. And I have these on each slide so you know at a glance which line of business this measure is referring to. So for tobacco screening and cessation, it applies across all 3 lines of business. The next one is screening for symptoms of clinical depression and anxiety. And this looks at your patient members 12 years of age and older who had an office visit with an eligible PCP type during the measurement year and who were screened for symptoms of depression using an approved screener. There is a list of acceptable screening tools in the 2018 Payment Transformation Guide on page 65. Claims reporting requirements, you can also refer to the 2018 code set for this measure, which is available in the Provider Resource Center. Adolescent Well Care looks at your attributed members aged 12 to 21 who had at least one comprehensive well care visit with a PCP or an OBGYN during the measurement year. American Academy of Pediatrics and Bright Futures recommended well care visits for ages 11 to 21. And such visits include history, height and weight, BMI, blood pressure, vision and hearing screening, developmental and behavioral assessment, physical exams, immunizations, and anticipatory guidance. For developmental screening in the first 3 years of life, this is the percentage of attributed member children screened for risk of developmental, behavioral, and social delays using a standardized screening tool in the 12 months preceding their 1st, 2nd, and 3rd birthdays. A complete list of acceptable screeners is available on page 59 of your Payment Transformation Guide. Okay, updates to existing measures. For breast cancer screening, I wanted to share some updates to the existing measure. We have 3 new service codes for numerator credit, and these codes apply to patients who elect to receive digital breast tomosynthesis in place of a traditional mammogram. While we're accepting these codes for numerator credit, tomosynthesis is still subject to plan benefit limits. So if it's not a plan benefit, your patient will likely receive an out-of-pocket cost. However, if they go to a specialist and they receive the service, the specialist bills these codes to us on their claim, it will give you automatic credit for your numerator count. Another change regarding breast cancer screening, as of January 1st this year, CMS released a memo which you should have included in your email along with your slides. And this is that the 3 codes you see on your screen have been discontinued. The G0202 G0204, and G0206. So please discontinue using those codes for reporting. However, they have replaced them with 3 new codes for screening mammograms. So 77067, 66, and 65 are the new codes you should be using. In regard to diabetes eye exams, starting in 2018, we're looking at patients who are 18 to 75 who receive a dilated or retinal eye exam by an eye care professional in the prior measurement year. Also, what's new is if your patient had an eye enucleation anytime during their history, you will receive numerator credit for that patient. Still in diabetes care medical attention for nephropathy, we are now looking at numerator credit to include sacubitril valsartan as an allowable hypertensive combination. So if your patient is taking this medication, you will receive numerator credit. And for diabetes care, your denominator criteria has been modified to include only outpatient encounters with a diagnosis of diabetes from the following provider types you see on your screen. So in other words, if your patient was hospitalized and the hospitalist diagnosed him with diabetes, we wouldn't count that and put that patient in your denominator since they're not listed as one of the provider types you see here. And then we're also including patients who were diagnosed with polycystic ovarian syndrome will be excluded from these measures. Okay, moving on to BMI. So BMI measure applies to members aged 18 to 74 years of age who had an outpatient visit. And the denominator criteria will only include outpatient encounters with an eligible PCP. So those are the PCP types you see listed here on your screen. And for immunizations for adolescents, we'll need to have at least 2 HPV vaccines with different service dates on or between the member's 7th and 13th birthdays. The first and second doses must be administered at least 146 days apart, or the patient must have had at least 3 HPV vaccines with different dates of service on or between the member's 7th and 13th birthdays. For flu vaccine, this is percentage of attributed members 18 and older who received the flu vaccine during the measurement year, and this applies across all 3 lines of business. Due to technical difficulties in transferring data, we weren't able to display results of the Sharecare Real Age measure last year on COSIVA, but that's been fixed. So now the Sharecare Real Age test measure is no longer display only. You are being measured on this. So we're looking at commercial members age 18 and older who completed their Sharecare Real Age assessment at least once during the measurement year. And as you can see, the thresholds are really low for this measure. Minimum threshold is only 5% with your target threshold at 10%. So last year we had some doctors who did really well in the Sharecare Real Age measure, and we found that one of the reasons that they were successful is they use some of the tools that we offer free of charge. We have handouts you can give your patients. We have those little prescription pads where you can note their biometrics, their blood pressure and lab readings. Those are not necessary to complete the Real Age assessment, but it will help the patient get a more accurate reading of what their real age translates to if they have their height, weight, blood pressure, waist size, and their lab readings. If you'd like any of these materials, they are available free of charge. There's a form available in the Provider Resource Center, or you can contact us at HMSA and we will send those out to you. For the weight assessment counseling and counseling for nutrition and physical activity, there's a new ICD-10 code for numerator credit, and that code is the Z71.82 for exercise counseling. So if you report this code on your claim, you will receive acceptable numerator credit. Okay, review of chronic conditions. This year, keep in mind measurement period will be ending September 30th. You will not have until the end of the year. However, we will still accept supplemental data through October 31st, and you will still have that 30-day claim run out for your RCCs. We also have a new patient exclusion. So if you have a patient who's living in a long-term care facility, or a patient's been institutionalized for at least 6 months during the measurement year with supporting documentation, you could submit a request for reconsideration to remove that patient from measures. So the R4R would need to be submitted each year. And for this year, we will begin accepting exclusion requests as of July 1st. So that will be once the patient's been institutionalized or in a long-term care facility, January 1st through June 30th. As of July 1st, you could request to exclude that patient from the measures. So we've covered all of the measures that fall under the PCP performance, but I wanted to take a quick look at the PO performance measures. While some of the measures, these are PO measures, but the PO as a group is relying on the individual PCPs to complete some of these measures. So the ones in particular are controlling blood pressure. While it is a PO measure, the PCP is going to be the one who's going to be monitoring blood pressure and perhaps prescribing medication or lifestyle changes. And for the children with special health care needs screener, that is another measure that is also going to be administered in the PCP's office. So we're encouraging all of our PCPs to continue treating their patients for blood pressure and administering the special needs screener because it's going to help your PO as a whole. Okay, moving on to engagement measure. Each year, 20% of the PCP's base PMPM band rate for each line of business will be at risk based on the PCP's performance on a limited set of foundational engagement measures. Engagement measures are intended to outline key behaviors or activities that help the PCP succeed in the new payment model. Engagement measures will be scored annually, which will determine the portion of the following year's base PMPM band rate that will be at risk and that the PCP will earn for each line of business. For each engagement measure, PCPs will earn either all or none of the credit across all 3 lines of business. The weight of the PCP engagement measures have slightly changed this year as from what they were last year due to the removal of the Share Care engagement measure. So once we remove that Share Care engagement measure, you can see it bumped up the percentage to 7% and 6% for the remaining measures. On the PO side for engagement measures, the PO will be evaluated on the engagement measures on a quarterly basis, and the measure requirements and thresholds can be found in Appendix E of the Payment Transformation Guide. Each quarter, HMSA will determine whether the PO meets or does not meet the requirement for the engagement measures. There will be no partial credit awarded, and credit for the measure will be applied across all lines of business. The weighting of the measures have not changed in 2018, so these are the same measures and weights as we had last year. Social determinants of health data collection will continue to be unscored in 2018 as they were last year. Physician organization must have an aggregate performance or quality score across all lines of business, and all member PCPs in the PO have the equivalent of earning at least 50% of the total maximum potential performance payments for the PCP performance measures during the measurement year. Total cost of care calculations will not include drug costs associated with drug plan riders and behavioral health services. So those 2 things will be excluded from the calculation. And the total cost of care performance will only be calculated on a PCP's medical spending trend for HMSA commercial plan members. There will be no other outlier exclusions applied to the calculation. So if you have an expensive patient who's in the hospital for an extended period of time, unfortunately, that will not be excluded from your total cost of care calculation. So going back a little bit to your COSEVA display, for total cost of care, it really gives you a lot of data and information. The data includes only commercial members again, and it doesn't include drug or behavioral health costs. You're able to see your top 10 patients with the highest cost and how those costs are distributed, as well as how your total cost of care compares against your PO, as well as how it compares against the entire HMSA network. So there's multiple tabs on this screen, and I've indicated them here with red arrows. Of course, you're not going to see red arrows when you go into your COSEVA, but because the screen is not really clear, it's hard to see. You can see there are actually 5 tabs at the top of the screen. So you can not only see your top 10 patients by cost, the other tabs will show you your top 10 patients for hospital utilization, your top 10 most frequent emergency department utilizers, those with the most office visits, and those with the most imaging claims. The following components can also be found on the total cost of care dashboard. You can see your PMPM social comparison graph, clinical panel risk score social comparison graph, your top 10 charts, cost utilization, hospitalization, ER, office, and imaging, and those are the 5 tabs we talked about. Your total cost of care breakdown bar, your total cost of care PMPM, and your PO median total cost of care PMPM. I just wanted to make sure you're aware of some of the tools and resources that are available to you. Of course, we have our provider toolkit in the Provider Resource Center, and it does not require a username or password. This contains an overview of the program, PCP selection form in several languages, sample payment reports, a guide to coding for performance measures, and other information. The link you see at the bottom of your screen will take you directly to the toolkit. Or once you're in the Provider Resource Center, just type in payment transformation in the search bar, and the first result will take you to this page. You could also access it via the HMSA.com webpage. Just scroll down and click on the link for providers. And then once you're on the provider linked page, we've got different sections. On the left, you see programs that will link you directly to payment transformation. And on the right side, you see training, and that will take you to all of our different training videos. Anytime you have questions or concerns, be sure to reach out to your PO leadership, or if you have questions that are more technical about COSEVA, definitely reach out directly to COSEVA. You can also contact HMSA at the numbers you see here on your screen, or email us at psinquiries@hmsa.com. We're here to answer your questions about your payments, your engagement or performance measures, or if your office needs training. Be sure to contact us and we can come out to your office. We also now have payment summary reports available in HHIN. So this is just kind of a quick look at where you would find it. If you scroll down on your left side menu and click on RTP, you can see there's 2 sets of reports here. You've got your global monthly payment report summary, and that's broken out by date. And then on the right side, you have your report to provider. The Payment Transformation Program Guide is also available via HIN, and this is a proprietary information guide, so that's why it's in HIN, and you need to have your username and password to access the guide. If you have staff who need access to HIN, be sure to contact us at the number you see on your screen so we can get everyone set up with their own unique username and password. Okay, so that brings us to the end of the slides. The remaining slides are just about patient attribution for your reference. And we do have a comment about Coziva, and as I mentioned earlier, we are using Coziva through the end of March of this year, and we will be moving to Choreo April 1st. And unfortunately, this webinar, we won't be really dealing too much with Choreo. We will be having, we've already had part 1 of our Choreo introduction. Part 2 is coming up on February 28th. If you haven't registered, contact us at PS Inquiries and we can get you registered for that. Not only are we doing a 3-part series on the web, we're also doing PO-specific training. So your PO will have specific training for your PO leadership or admins, and then we'll do PCP trainings as well. So we're having lots and lots of training opportunities throughout February and March before Choreo is rolled out to the public. So I do see a comment that someone has been doing the metrics for all of 2017, and are they new metrics for 2018? Actually, so some POs have been doing the metrics for the entire last year, but we do have some POs out there who remains on pay for quality measures, and so these performance measures, some of them are new for them in 2018. So unfortunately, there was a different mix of people getting payment transformation, global payments versus still being on fee-for-service. But now we've got everybody all on the same page this year. So everybody's all on global payments and all in payment transformation measures. So another question, does the patient need to do a real age assessment each year, or is it just once and done for life? Unfortunately, this is a yearly measure. Because patients' health will change from year to year, it's good for them to go in and do an update, reassess their real age. You know, maybe they've made some lifestyle changes, eating better, exercising more, their numbers could improve and they'll see a lower real age. And so taking the real age each year will actually help them determine what changes they can make to improve. So the unscored specific social determinants of health, right now they're unscored, and I'm sorry I don't have the list in front of me, but there is a comprehensive list of social determinants of health, and those are things like age, ethnicity, household income. I'm sorry, I don't have that list in front of me, but I think, if I'm not mistaken, they are in the Payment Transformation Guide, and I can get back to you with where exactly to find that information. Okay, so I have a question regarding new band sheets. I actually don't have a specific date. The last I heard, we're targeting, I think, July. But I will check with the SRM group and see if there's any new information as far as band sheets or renegotiating bands. I'm sorry, I don't have that information right now. As far as payment summary reports on HHIN, I think at this time it is providers only because there's financial data. I don't know that all staff would have access, and a lot of times our provider doctors don't allow staff to have access to all of the financial information, so it may be just available to doctors at this time. So another question is, why is influenza by calendar year and not flu season? Unfortunately, we tried to make measures easier to track by doing it calendar year rather than rolling quarters or partial year. And I know flu season is not January through December. It kind of overlaps winter through spring. unfortunately, that's just, you know, one measure out of all of our measures that doesn't fall nicely into a calendar year. So we do have a question on long-term care facility, and I know this question has come up in the past. What is considered a long-term care facility? I haven't gotten a very clear answer on who we would consider a long-term care facility, but of course, a nursing home with like a skilled nursing facility, that would be a long-term care facility, but I'm kind of thinking like a residential care home probably wouldn't be qualified because the doctor still goes out to the care homes. But I will still continue trying to work on getting a list of the acceptable facilities. Okay, we have a question about share care. Is there a waiting period where they can retake their real age assessment? So if they did it in December, can they do it again in January? I'm not too sure, but I would think that it resets every January 1st, but I will double check on that and get back to you with that answer. Okay, for this question about when the new PMPMs for 2018 will be presented for review, again, I think it's coming out in July, but your SRM or provider engagement lead will be working directly with you because I haven't heard from that group exactly when they're planning. I know we're talking about recontracting sometime mid-year, but as soon as we get that answer, we will send that out to you. Okay, regarding diagnosis coding for physical activity, Z71.89 changed to 71.82. I'm not too sure. I'll have to look that up, but I know that we just decided that that was an acceptable code. Sorry, I'm trying to find that slide. Okay, so the new code Z71.82 for physical activity. You actually can still use Z71.89 and you will receive numerator credit. So I'm hoping that answers your question. You can use either code. Okay, for patient exclusion in long-term care facility, supporting documentation needed, you would need to show that the patient has been in that facility for the appropriate amount of time, at least 6 months. So if you can show the admission and discharge, or if they're still admitted to that long-term facility, that's what we're going to need to see that the patient is in long-term care, and that's how we will exclude them from the measures. Okay, we have a question regarding patient education for regarding payment transformation. I haven't heard anything, and I will take this back because, you know, we do need to make patients aware. I know there's been a lot of controversy, especially for our PPO patients they feel like they can't choose their PCP because we've been asking them to sign these patient attribution forms or patient attestation forms. But I'll go back to leadership and find out, will we be doing any kind of member education, and if so, what that would entail. Okay, regarding the tobacco screening, if a patient has diabetes or hypertension, do those ICD-10 codes meet numerator credit for that measure? I'm not too sure exactly what you're asking, but basically the tobacco screener is a questionnaire. So you would still give that to a patient who has diabetes or hypertension and then code accordingly your claim that you have screened the patient for tobacco use. And if that doesn't answer your question, please type it in and clarify. There's a couple of questions that I'm not able to answer at this time, and what I'll do is I will find the answers to those questions and I will reach back directly to you. So if I wasn't able to answer your question at this time, I will get back to you either today or tomorrow with that answer. Okay, so once again, thank you so much for joining us today, and I will get back to you if I wasn't able to answer your question on the webinar. Please keep up the good work you've been doing with payment transformation. We really appreciate all of your hard work. We will be repeating this webinar on April 4th, so hopefully we'll have more answers and any updates to the program. We will roll it out on April 4th. Okay, thank you so much for joining us, and have a nice rest of your day.